Hello everyone, how are you all doing? Let me know if everything is displaying appropriately and whatnot. Alright, hello Kylie, how are you? Yes, aren't we all still home, unfortunately? Hopefully everyone's sanity is still relatively intact. I was on the fortunate side to not have much sanity to begin with, so it was not much of an issue to lose anymore. Hey Stephanie, yeah, I agree. It is rough out here, for sure. And we'll get started in just a couple minutes and everyone else join in. Let me know if the sound is okay. Hello Christina, how are you? Wondering if the 12:30 time slot will get more people involved in real time. I know that 10 a.m. wake up can be a little rough for some people. I'm going to open up the sticky board too. I'm doing pretty good, Christina. Just trying to stay inside and not go too crazy. Has everyone had a chance to watch Tiger King yet, or if you're going to? Because I finished it finally, and it was pretty interesting. I recommend everyone should. It will give you a new sense of what true crazy really is. I got that too, Sarah, for sure. When I saw like where the Tigers were all at, and they all popped up just in Florida, like I was definitely feeling a lot of that Floridian pride for sure. And then I actually got to thinking, I was like, it's only $2,000 for a tiger. Like, I reasonably could make that happen. I don't know if quarantine's a good time to do so, but who knows? Maybe that's in the cards for me. Yeah, some odd impulse purchases while on quarantine. It's very true. I would have some time to train it. Although the cubs were pretty cute, but yeah, when they said like, yeah, in a year they're like 300, 400 pounds, like it sounded pretty nuts. Okay, so I'm gonna go ahead and get started. You can keep posting questions if you have any in the chat there. I'm going to start recording for everyone at home, or people at home who may not be watching just yet, but we'll say hello to them in the future. Okay, so I did have a good question that came up here, and I figured I would address it while before we get started in earnest here. So hopefully you guys can see that. Basically, there was a question that I think is actually a really good one, because I probably say these things and maybe not take as much time to consider whether everyone's kind of on the same page with me. And some people are too polite to stop me and be like, what the heck are you even talking about? But so question here. So randomly and possibly stupid question. There are no stupid questions when it comes to farm stuff, but I still don't have a good grip on it. Is there a difference between drugs that are considered anticholinergic, antimuscarinic, antihistamine, anticholinesterase or cholinesterase inhibitors. Okay, so couple of things to kind of work through here. So some of this is just like straight nomenclature. Some of it could be maybe more specific. So when I say anticholinergic, really all that means is it's something that's blocking the effects of acetylcholine, right? So, and that's kind of a broad term because technically that could refer to antinicotinic and antimuscarinic drugs. In general, when I'm talking about it, I'm mainly focusing on the antimuscarinics, mainly because those come up much more frequently. That's going to be the things you're going to see all the time, whether it's for urinary incontinence, whether it's for COPD, whether it's for whatever. For the most part, the grand majority of drugs that are anticholinergic are antimuscarinic for the most part, right? Now that we do have some that are anti-nicotinic, right? We've seen a few of those. If you recall back to your surgery section and you saw drugs like, say for instance, rocuronium or vecuronium, like those are considered anti-nicotinic, and that causes paralysis, right? Because they work on those nicotinic receptors on the skeletal muscle. So antihistamine just means what it states. It just means it's blocking the effects of histamine. And that, again, can be sort of a broad term because you're talking about which histamine receptors are you talking about, the H1 versus H2. Most of the time we say antihistamine, we most often mean H1 blockers for the most part. Now, it just so happens that most of the antihistamines we deal with, for the most part, especially the first generation ones, also have secondary effects to have antimuscarinic properties, right? So things like Benadryl or doxylamine or chlorpheniramine, any of those antihistamine drugs, the first generation ones, typically have antimuscarinic properties, which is why you get all of those, the sedation. That's why you end up seeing, the urinary retention and drying out effects and all those things. Those are the antimuscarinic effects, antimuscarinic effects of those particular antihistamine drugs, right? But you could technically say that your H2 blockers, like, say, for instance, cimetidine, is also antihistaminic. It's just more specific for H2 blockers or H2 receptors specifically, right? So there's that. There's not really anything that I would say, we don't really use the term anticholinesterase. I wouldn't know if that's really a term I've ever used, but cholinesterase inhibitor, for sure, that would be something we've talked about previously. So if you go back and talk about things like, say, neostigmine, which we talked about in terms of helping to reverse some of your paralytic drugs. We talked about some used for things like, Alzheimer's disease, for instance. I almost forgot Alzheimer's disease, right? But basically, you'll see that by using a cholinesterase inhibitor, by blocking the enzyme that metabolizes acetylcholine, you end up having increased overall activity of the parasympathetic nervous system, but that mainly has to do with the muscarinic effects. Well, if you have a cholinesterase inhibitor, and say it's not very specific for, it just works on acetylcholine, right? So that means you can have nicotinic and muscarinic effects as well. You can kind of have a bleed over between the two, which will be a great segue when I talk about the toxicology stuff coming up, say in the next lecture or two. We'll talk more about acetylcholinesterase inhibitors, which are important, not only for the drugs we've mentioned, but there's also some things like, biochemical terror attacks and things like that. A lot of nerve gases happen to be cholinesterase inhibitors, so we'll get more into that in a few lectures here. Speaking of which, so I remember, I think it was Courtney that brought it up last time, but we were talking about ranitidine and saying that it was removed off the market, and that's actually true. I did a little bit more reading up on that. And that was an interesting thing. Some drugs, when they got taken off the market, so if you recall back, and I think it was Valsart and that was removed, that was due to sort of an impurity that was introduced into the drug during the actual manufacturing process, and it was potentially carcinogenic, and so they got rid of that. Well, the interesting thing with ranitidine is that actually it came about, there was a carcinogen that the drug at high temperatures could actually break down into this carcinogenic compound. There's a nitrosamine, I believe, was one of the products. And so that's really kind of interesting because that just means that the drug itself can become carcinogenic, especially when kept at high temperatures. And guess where we live, right? We live practically on the surface of the sun. So, you might imagine that could happen, especially if it's left out in, say, a delivery truck or out in your car or something like that. So that's why ranitidine got removed from the market entirely. I might have a mention of it later on, but I'll have to remove that and update all my slides, unfortunately. But So there's that. So it's interesting, but no more ranitidine. Don't like to use cimetidine, so it's really famotidine or nizatidine. They're going to be the ones to go to. But okay, another question. In our gyne class, gabapentin is a drug to help with menopause. Does that have to do with dopamine? Why would gabapentin help? And I believe I mentioned this in my OB-GYN slides as well, but these help out with some of the vasomotor symptoms, like the hot flashes and things you can see with menopause. And so it doesn't really have anything to do with dopamine. Gabapentin, as you might imagine, has to do with kind of modulating GABA, right? That's why we use it as like maybe an anti-epileptic, even though you really don't see it used for that very often. But we do use it for like a lot of neuropathic pain concerns, so like fibromyalgias and MS and all these kind of things that present with neuropathic pain. I think the idea is to kind of help tamp down the activity of these kind of overactive, maybe nociceptive nerves and things like that. So why it works specifically for patients with vasomotor symptoms and menopause, like we don't really know the full mechanism, I don't think. Nothing's really been posted specifically to mention why that might work. We just know it does, right? Similarly, things like your SNRIs like duloxetine may have some effect on working for that as well, right? So it could be nice if patients have concomitant conditions that may require gabapentin anyway, that maybe you get some double duty out of that drug potentially. So that's something you may see. But if that didn't answer your question, then let me know and I can try to get back to it. So, all right, let's get into our lecture unless anyone has any other questions in the meantime. Actually, I do have one good quarantine story. I was actually... I was kind of getting cooped up too much in my house, and I decided I really wanted to get out. So I went ahead and broke the stay-at-home order, and I was driving around in my car, and I actually got pulled over, which was pretty unfortunate. And so the police officer came up, and he's like, I stopped you, and I was like, yeah, probably because I'm outside of my house. And then all of a sudden he started crying, and I was just like, oh my gosh, like what's up with this police officer? Why is he crying all of a sudden? And I asked him, I said, sir, are you okay? Why are you crying? He goes, because it's a moving violation. Anyway, it's tough because I can't hear your silence in real time, so it's tough to tell how bad the joke really is. But regardless, yes, very good, Kylie. Hope you enjoyed that one. All right, let's get into our ACLS talk. So you will get more of this when you get into the summer semester. Certainly see a lot of this when you get into your emergency medicine rotations, when you get on rotation. It's not an if, but I think a when, based on hopefully how things will progress. But regardless, here are some of the medications you run into most frequently in your ACLS classes and the actual ACLS situations. Some of these we've talked about previously. We will bring these up again and maybe talk about how we're using them specifically in the emergency setting. And so some of this may be review. There may be, I'm trying to think if there's any new drugs specifically, but it does not look like it. So we'll cover these. So one of the first things that comes up first, and this may be a situation where, especially if you're on rotations, you may be asked to actually like prepare some of these medications. I've seen that happen certainly with PA med students before. What's kind of interesting is that a lot of the drugs that actually come out, they actually come in this either like an Abiject or a Bristeject is the name for this kind of proprietary syringe setup. And basically this is kind of nice because basically you have the drug in a pre-filled glass syringe or glass vial, and then you have the barrel of the syringe itself here. So you'd actually have, there's a small needle here that actually pierces this rubber grommet. And then here you can either take off this this yellow piece, and then you have a nice lure lock that can be hooked up to, like, say you have an IV already placed in the patient, or potentially you could just take off this whole thing and you have a needle you can actually use to inject into the patient directly. So most of the time we don't do that. We just use the lure lock tip here. But anyway, so one of the things that you'll always find, especially you'll probably do if you're in the middle of a hectic code situation where a person is actively trying to die in front of you, and they're like, oh, get this med out. And of course I did it wrong the first time. I think most people do it wrong the first time, but you have to make sure you're opening these things appropriately. So for instance, here there is an opening at the bottom. If you open it at the wrong end, actually the drug won't come out, and then you're sitting there fiddling around with it while someone is like, I need that med right now, and then then you look like kind of silly. But anyways, you have to open it at the right end. The drug will come out, and basically these you'll take off this yellow cap here. There's a yellow cap here you'll remove, and then you actually twist one into the other, and so that way then the medication is ready to administer. And most of these are going to be like in a dose that's already ready for an adult patient, but for instance with like a pediatric dose, we have to draw out of this in order to get the specific dose that we need for our particular patient. So again, here's just another picture kind of showing you the same thing, how you remove the safety caps here, and then you basically apply the drug into the barrel, twist it in so that way the needle will pierce that rubber, and then you can go ahead and administer the medication directly to the patient there. Again, just some pictures kind of showing you how to actually do that, because you probably couldn't see my hands when I was pantomiming how to actually do that. But if you can get this right the first time, then you don't look quite so silly, and you look like you actually know what you're doing, which is really important during a code, because you typically don't want to look like you don't know what you're doing, even though you may not feel like it. So anyway, so let's talk about our medications. We're going to primarily use, in the case of, we'll talk about bradycardia first, and then get into some of our tachyarrhythmias in just a little bit. Obviously, any heart rate less than 60, you can consider to be bradycardic. Even that might be normal for some patients, but we'll get into kind of how we manage this. So first drug we have is epinephrine. We probably have mentioned this quite a bit in terms of thinking about it as a natural sort of component of things that we release from the adrenal glands. Like we kind of know what it does broadly, but let's talk about it in terms of a medication, how we're going to use it in this kind of code sort of situation. So it's an endogenous catecholamine. We naturally produce it, as I mentioned there, and it kind of has a nice balance between both alpha and beta stimulation. So as you might expect, you're going to get to see increases in heart rate. You're going to see increases in cardiac output. You should, and again, when we talk about inotropes versus chronotropes, remember those terms. Inotrope has to do with the actual squeeze of the heart, being the contractility. Chronotropes are going to have to do with the actual the rate of the heart itself. So this will be both a positive inotrope and a positive chronotrope, right? So it's going to do both here. It can also help out with things like coronary perfusion, and you will see the blood pressure should also increase as well, which is good if you have, say, a patient who is bradycardic, you want to get the heart rate up, or say they have no heart rate whatsoever. This can be potentially used to try to help stimulate the heart to get back to, hopefully, a return to spontaneous circulation, even though it may not potentially occur. So here you can see that this is typically indicated if we have patients who maybe have like symptomatic bradycardia, say they have evidence of poor perfusion, they're starting to look kind of dusky or cyanotic, and their heart rate's below 60, things like that. Or we will frequently see it used in cardiac arrest or VFib, VTAC, asystole, or PEA. Keep in mind here that this is probably going to be like the number one most common medication you're going to give in a code situation. And when we get to the algorithms in just a little bit, you'll see that basically this thing is going to be given every 3 to 5 minutes or so, pretty consistently. So basically how we're going to administer this, and I'm not going to give you any questions regarding the actual doses specifically, but I just want to give you an idea how we're actually using this here. So every 3 to 5 minutes or so, typically for most adult patients, are going to get a 1 milligram dose. And this is something where, epinephrine is, typically you'll see it like in the case of anaphylaxis given as like an IM sort of solution or IM injection. If you're using this, say epinephrine plus lidocaine, this will be maybe like an intradermal injection or something for code situations, because the patient is, for all intents and purposes, dead potentially. We're using this IV, right? Or you can use it through an IO. If you recall, if you have difficulty getting an IV, you can get one of those IO kits out and actually establish, a route, say, through the tibia or something like that. So it used to have this really bad nomenclature back in the day where it used to say things like 1 to 10,000 or 1 to 1,000, and it had to do with the concentration of the drug you were administering. And this is really important because that also dictates, based on the dose you're giving, how much volume you're going to be administering. So for instance, 1 milligram in this 1 to 10,000 solution ended up being like 10 mLs, versus if you're trying to give 1 milligram of this 1 to 1,000 solution, it was only 1 ml that you're administering. This is important because if you're trying to give 1 milligram and you grab the wrong solution, you may be either giving, say, like a 10-fold overdose or a 10-fold underdose, either of which is not great for the patient, especially depending on kind of what their situation is. So they're starting to get away from this nomenclature and trying to just give you a straight concentration. So okay, is it 1 milligram per ml? Is it, say, 0.1 milligrams per ml? Because this is important in terms of how you're using it. So for instance, if I'm giving something intramuscularly, you don't want to use a lot of volume. So typically you're going to use a more concentrated form. If you think like an EpiPen or something like that, that's the more concentrated 1 milligram per ml concentration, as opposed to an IV dose. Like typically, because I'm giving this IV, volume is not such a big issue, and I want to be able to better titrate a dose. And it's easier to titrate a dose if I'm giving something out of a volume of 10 mLs than I would if I'm using a volume of 1 ml, right? It's easier. You have more kind of play in that syringe in order to get the right dose, which could be important for like a pediatric patient, right? So anyway, so IVIO is typically preferred in a code sort of situation. What's interesting too is if you had absolutely no access to the patient from an intravenous standpoint, or you have no IO kit available, we actually can give some of these medications through the ET tube. There's a mnemonic I used to remember the drugs you can use there. It's called lean. I know it's not lean like the drink, like your purple drink. But lean stands for lidocaine, epinephrine, atropine, and naloxone. Those are 4 drugs you can actually give via the endotracheal tube. As you might imagine, you're going to see that bioavailability out of the endotracheal tube administration is not as good as it would be if you're using IV. So typically the doses are a lot larger. So for instance, a max dose for epinephrine via IV, it's only 1 milligram. When you're using it via the endotracheal tube, it's like 2.5 milligrams would be your max dose. So it kind of goes to show you you're not going to get 100% bioavailability out of that endotracheally administered dose. I'm only mentioning just from more sort of historic perspective. I'm not even sure if they'll really cover it in your ACLS class, but if you ever hear about this, that's kind of when you would do it. But nowadays, access is much more readily available because most EMS groups and things like that have access to IO kits and whatnot. So it's less often you're going to see this, if ever. So as I mentioned, that nomenclature in terms of how you express the concentration can be really difficult. I'll give you an example of how this almost went really wrong for a patient. So I remember when I was in fellowship, and one of my rotations was, or a lot of my rotations were in the ER, and we had a patient coming in cardiac arrest, and so patient was being actively worked on, so they're actively doing CPR, and basically I was helping out with something else, I think, and the nurses were handling the medication. So there was 2 nurses who were trying to get the medications ready, one of which was the senior nurse and one of which was a relatively new nurse. And so basically the senior nurse was giving directions to the junior nurse to kind of give her some hands-on experience to try to get ready to learn how to do these tasks. So anyway, what's interesting is if you're looking at a code cart, for instance, you may notice that there's those pre-filled syringes, like I showed before, that are the 1 milligram dose of epinephrine. But we also have in there a 30 milligram, 1 milligram per ml vial that we keep in there as well, because if you need to make an epi drip or something like that, you have this bit large vial. So again, the pre-filled syringe is 1 milligram. This vial is 30 mLs. It's 30 milligrams. So it's quite a lot more drug, right? So anyway, one of the nurses was like, okay, well, let's go ahead and give epinephrine. And so the junior nurse, the senior nurse was looking at the patient. She was more, focused on that. The junior nurse goes, oh, do I do the whole thing? And so the senior nurse was like, yeah, do the whole thing. Not realizing that the junior nurse was holding up one of those vials of the 30 milligrams. So she ends up drawing up that entire thing and hands it over to the nurse. And had she not been looking at it to see like, wow, this looks weird. Why is it 30 mLs versus 10 mLs, that could have been given to the patient. So instead of giving 1 milligram, you would have given 30, and that basically would probably have caused the patient's heart to explode had it not already stopped beating completely anyway. So it goes to show you medical errors can be very likely to occur in an emergent situation, especially when you think about how quick things are happening. From the time that a provider says give this medication to the time it's given is usually within seconds to a minute, versus elsewhere maybe hours or even days in some cases, right? Anyway, so because of that issue there, because of things like CVAs and hemorrhage and whatnot, leading to either giving too much or too little, they've gotten away from that. Now they just give you the concentration strictly as like 1 milligram per ml, 0.1 milligram per ml, whatever the case may be. So you'll see that. But if you ever hear old school providers talking about 1 to 1,000, 1 to 10,000, or even sometimes you'll see this on like local anesthetics, like if you see like bupivacaine, it may say like 1 to 200,000 or something. That's the concentration of the epinephrine you're seeing there. So as I mentioned, the endotracheal tube dosing, I like to use lean as my mnemonics to remember that. Again, rarely will this be done, but just keep in mind that the dosing is going to be different, usually 2 to 2.5 times different in terms of the dose. But we can see there with epinephrine, you're also using a much different concentration when you're doing that to make sure you're not kind of flooding the lungs with a lot of volume there. So, all right, so then up next we have our atropine, which is good because this kind of follows in along with our talk about antimuscarinics. And so atropine is a pretty standard antimuscarinic drug. Basically, it's going to be also termed a vagolytic, meaning it's going to be decreasing the activity of the vagus nerve or the parasympathetic nervous system. And so you might imagine what the side effects are going to be. We've covered these ad nauseum, but they have the whole mad as a hatter, dry as a bone, red as a beet, hot as a match, and blind as a bat, I believe was the last one. So you get all those typical effects, but what we're using it for typically here is to try to get the heart rate up. So we can typically use this for symptomatic bradycardia, most likely, either if it's like vagally mediated or if it's I do like AV block. That's where you're most often going to see it being used. We used to use it for cardiac arrest, and you'd actually end up alternating between epinephrine and atropine. You kind of give one dose of one and switch to the other. That is not recommended anymore, and so nowadays, and this will be seen on the algorithms, you're going to see that for cardiac arrest, you're really just sticking with atropine. I'm sorry, you're just sticking with epinephrine. Atropine is only going to be used for symptomatic bradycardia. But there could be some other uses for it too. So like we mentioned with the RSI talk, we said this may be useful if you have patients who are maybe about to vagal down from the succinylcholine they're receiving, or just do the laryngoscopy, or maybe they're particularly having a lot of saliva, maybe due to like ketamine or something, or they may have a just a excessive salivation issue anyway, and this can help to dry them out from that standpoint. I apologize if you can hear the vacuuming in the background. I'm not sure why that's occurring right at this moment, but it is what it is. Here again, you can see the typical dosing you're going to administer. Again, don't memorize the dosing. I'm just having it here just for reference's sake. So up next, let's talk about our tachyarrhythmias and drugs that we can use to manage that. The first one's going to be adenosine, and so we've talked about adenosine before, and when we were mentioning our antiarrhythmic drugs, and so typically this will see its use with things like supraventricular tachycardias specifically. If you recall, this drug also has a really short half-life, and that's why the administration of it has to be very specific and make sure you're pushing this stuff really fast in these cases. But ultimately what it is like adenosine, as I think about it, is kind of like pulling the emergency brake on your car. It's going to basically kind of stop everything essentially, and because it's such a short half-life, it's kind of like hitting the on-off button on your computer or something, right? It's going to shut everything down for a second, and then everything should come back relatively normal, right? So that's why I use it for SVT. And again, if you've ever seen it, or if you will see it on rotations, I recommend you check it out, because they typically have a continuous EKG going on the patient. They'll sit in there and be tacking away, and then you administer the adenosine immediately, flatline for a second, and then hopefully the patient goes back in a normal sinus rhythm. And you typically use this if patients are not responding well to other non-pharmacologic measures, things like vagaling down or blowing on through a straw, things like that. Notice here the dosing, you will end up doubling if the first dose doesn't work. But what I do see a lot of times that patients are not really getting the full effect of the dose because the providers are not giving it quickly enough. And remember, typically we have that three-way stopcock setup where you would end up having one end hooked up to the patient, you would have one end hooked up to a saline flush, usually 10 mLs, and then the other one to the drug. And so basically push the drug, push the flush behind it to try to get it back to the heart as quickly as you can to prevent that degradation. Because again, most of these patients are going to have peripheral lines set up. They're not going to have central access available for the most part, because you're probably picking these patients up off the street or from walking into the ER. The peripheral IV is all you're going to have in a lot of cases. So here's that stopcock that I mentioned here. The biggest mistake that people will screw up is they don't realize that this is the off switch, meaning whatever direction this is pointing is not going to get any kind of flow through it. So if you want this to work as a three-way setup, you have to point this in the opposite directions. That way everything can flow through. I've seen people screw it up to where they have the off switch over to either the patient, which the patient gets nothing at that point, or they'll have it switched up to the drug, where then they don't get any drug coming out. So it's easy to screw this up if you've never done it before. So that's why you want to make sure flush it well and then get all that drug to the patient the first time. Okay. Up next is going to be amiodarone. So we know this to be a class 3 antiarrhythmic, and has a lot of a variety of pharmacologic actions. Not only does it block potassium channels and prolongs the refractory period, which is why we like it, or why it's classified as a class 3 antiarrhythmic, but also it has some other effects, things like blocking calcium and sodium and all these things there. And so this is going to be handy to help slow down ventricular conduction for the most part. So what we're going to find is that we use this for basically any kind of arrhythmia for the most part you're going to see within ACLS kind of settings. That means that if I have like SVT that maybe not responsive to adenosine, amiodarone is probably going to be the next thing you go to, right? If you're having wide complex tachycardias, amiodarone is probably going to be the thing you're going to go with. Or if you have things like VFib, VTAC, amio is going to be kind of your go-to drug there as well. There used to be some other antiarrhythmics, which we'll mention here, but for the most part, the algorithms really just say amio is kind of the go-to drug for basically anything. So here you can see that we can give multiple doses to try to get the heart under control, but the really important thing to understand is that if it works, if it gets the patient back into a normal sinus rhythm, you have to follow it up with a drip, right? So that way we're basically giving a loading dose to get the patient up to steady state. Because if you recall, amiodarone's half-life is extremely long. It's many, many days. If you were to give it at a typical, just start with a drip, I mean, it would be a year before they'd get to steady state, which in these cases, you probably don't have a year to wait. So giving that loading dose gets them up to steady state, and then you immediately follow up with the drip if it's working, okay? Typically, if the patient still has like a perfusing rhythm, you give it over a longer period of time in order to prevent hypotension and bradycardia. But if they're in cardiac arrest, right, if they're in VTAC, VFib, and they're not perfusing, you go ahead and just give it IV push. The patient's probably unconscious at that point anyway. There's not really going to be any issues there. So you give it IV push, try to get them back to a normal sinus rhythm, hopefully. But otherwise, you can give it over a longer period of time, like an hour or so. So we used to use more lidocaine as an antiarrhythmic, but nowadays that's really been supplanted by amio. But if amio is maybe not effective, then you may try something like lidocaine as a backup. And if you recall, it's a 1B antiarrhythmic, meaning it's mainly going to be blocking sodium channel. And that's also, if you recall, the 1B antiarrhythmics like to work in areas of ischemia, which is good if you had someone with like a heart attack, for instance, that was having that developing areas of ischemia. That's probably where the arrhythmias were being developed anyway, due to those ectopic foci and things like that. This would only be used for ventricular arrhythmias. So whereas amio could be working as sort of broad spectrum, working for both atrial and ventricular arrhythmias, lidocaine's mainly going to be working just for the ventricular ones, right? And it can be used if maybe amio is not available for whatever reason, right? Keep in mind that this is another one you'd probably get bolus dosing to get them under control in terms of the arrhythmia, and then you follow it up with a drip as well. Be aware that patients who have, let's say, liver dysfunction, if they have hepatic impairment, or kidney dysfunction, they're going to have decreased clearance, and so you have to make sure that we actually kind of adjust our dose to watch out for that toxicity. Because if you recall, not only can these cause arrhythmias, them being local anesthetics, but also CNS toxicity can be a risk as well. And if you recall, back when we were talking about surgery stuff, patients will talk about like the tongue getting numb, or they'll have like metallic taste in their mouth. That's signs that you're having that CNS toxicity. It can lead up to seizures, so you should be really cognizant of that if your patient's able to communicate those sort of things. So again, this is another one you could potentially use intratracheally, but again, you'll not be using a whole lot of lidocaine for code situations anyway, so you probably don't need to recall that all that well, but it helps make the mnemonic work, that lean mnemonic, so we'll keep it there. And again, you can see here how you'd adjust the dosing and the infusion in order to account for their difference in organ function. CHF is another one you'd want to consider dialing down the dose, mainly because of the fact that they typically have a lot of hepatic congestion. They may not be able to get that drug kind of processed through the liver to actually metabolize it in the first place. So we also will use magnesium, and this is very specifically for torsades. Like I know you all are screaming at your computer right now. It's for torsades, of course. Note here that typically we'll give a max of a 2-gram dose to these patients in order to help treat this arrhythmia. Remember, this arrhythmia typically comes about from QT prolongation, either a congenital issue or, from my standpoint, a drug-based issue. And again, what's kind of interesting, and I probably mentioned that last time, is that what's their big rush for nowadays? Well, hydroxychloroquine and perhaps azithromycin, and both of those can prolong the QT and cause this particular arrhythmia, right? So thank you, Michael, for calling it out for me. So be aware of that. You may see need for this based on patients having QT prolongation due to medications that they may be taking for another condition completely, right? Biggest thing you're going to see with magnesium is that typically with like big doses given quickly, you can see a hypotension. If you recall, magnesium is kind of like the body's natural calcium channel blocker, which is why you end up seeing flushing. You can see the hypotension. So typically we're giving like big doses of magnesium along with fluids in order to make sure that you keep that intravascular space tanked up and the pressure doesn't bottom out. And again, you'll use magnesium for a number of different conditions, preeclampsia, use it for asthma, you can use it for all sorts of things there. But in this particular case here, we're using it for torsades specifically. Up next, we have sodium bicarb, and so we use this all the time for lots of different things. We'll talk about hyperkalemia more specifically a little bit later on, but I use this a lot for different poisonings. We'll talk about this in the upcoming lecture set, but things like acetaminophen, aspirin poisoning, we can use it for TCA poisoning, all kinds of different things we can end up using sodium bicarb for. But the main thing you'll see it being used for specifically is usually to help correct acid-base disturbances, right? So often when patients are coding, they get very acidotic because they're not breathing effectively, they're not perfusing effectively. The tissue starts to go into anaerobic metabolism, and that generates a lot of lactate and other acids. So they get very acidotic. And another thing people don't think about a lot is the fact that as the body gets more acidotic, you also find that things like proteins tend to denature, such that, for instance, things like epinephrine doesn't work as well at the receptors. So that can also worsen your condition from a cardiovascular standpoint as well. So normally we like to maintain that normal pH as best we can, although it may be quite difficult depending on the situation. Typically, 7.45, 7.55 in some cases, but we'll use that if we're trying to alkalize a patient, if we're using for certain poisonings, but otherwise you want to keep between 7.35, 7.45 for a kind of typical normal physiologic effect. But some of these coding patients, you may find them getting down in the 7.1, 6.9, especially like DKA patients, they can get down to 6.9, 6.8. It can be pretty severe, and bicarb may be useful for that. So keep in mind there's two different varieties of here you'll find in code cards frequently as well, and this can be another source for confusion. So for instance, they have the 4.2% and the 8.4%. The smaller concentration is typically used for infants, and so it usually comes in a smaller size anyway, like a 10 ml vial versus the 8.4% comes in the big 50 ml vials you'll see here. This is another frequent thing that goes on shortage a lot for whatever reason, even though it's like baking soda, but for whatever reason it goes on shortage quite frequently, and so sometimes we'll have to sub it out. And a little bit of trivia for you, you can actually use sodium acetate as an alternative. Acetate actually gets converted in the body into bicarb, and that can be a useful thing to help out with alkalizing and maintaining normal pH. Some things you can find are kind of a transient hypocalcemia, which can result in tetany if you're giving this very quickly, or if you're giving big doses. So that would be one adverse reaction you want to check out for. And so speaking of calcium, next we can use that, and you'll find these frequently in your code cards as well. So yeah, they can be used to replace calcium for hypocalcemia. We'll also see it being used for hyperkalemia, which we'll talk more specifically about a little bit later on. We also use it for things like massive transfusions, right? So imagine if you're giving blood, you don't want that blood to coagulate in the bag itself when it's waiting to be given to a patient. And so frequently they use things like citrate anticoagulants to prevent the blood from clotting. And so that does bind up a lot of that calcium. So you may be giving patients a lot of units of blood in order to help them with their trauma or their massive bleeding, whatever the case may be. But they're missing a lot of calcium out of that. And so sometimes we'll have to replace that by giving them some additional doses of calcium, try to keep that in a normal amount. So this is another one that has two varieties you're going to find in a typical code cart. And this is a good thing to know anyway, because you might run into this with some regularity, depending on what kind of unit you're working in or what field you go into. So there's two main varieties of calcium we're going to run into. There's calcium gluconate versus calcium chloride, okay? These are not equivalent, even though, and it's interesting because I think I have a slide here. If you notice, these two look almost identical to one another. If you're looking at it, you can see here that they both are 10% solution. They both come in a 10 ml vial, and they both contain 1 gram of their respective calcium salt. So if you're not looking, it's very easy to give one for the other, but that would be very deleterious to your patient because they're not equivalent in terms of the elemental amount of calcium they contain. Okay, so basically what that means is that for every 3 grams of calcium gluconate, that equals 1 gram of calcium chloride. So what you would need is 3 vials of this to equal 1 vial of this in terms of the calcium content. That's important because if you were to think you're giving calcium chloride, but you're giving calcium gluconate, well, guess what? That's only a third of the dose you expect to be giving. Or you do it the other way, you can give 3 times as much calcium as what you expected to give. So those are things to consider there. Make sure you're looking at the vials because it's very easy to screw that up. The reason why there's this conversion is because the gluconate molecule itself is just a lot larger than just a simple chloride ion. So that's why there's that conversion between the two there. Other things to consider with calcium is it tends to be really rough on the veins, especially calcium chloride. It can cause pretty severe thrombophlebitis and really irritate those veins. And so that's why we always like to give calcium chloride via central line if at all possible. But if you have a patient who's actively dying and they're coding, then you may want to go ahead and give that via whatever line you have available to you. Calcium gluconate is going to be easier on the veins, and so you're more likely to see this being used peripherally. But remember, you have to give 3 times the dose essentially in order to get the same amount of elemental calcium as you would for the chlorides. That's one good thing to note about these two here. As I mentioned, if you have extravasation, especially of calcium chloride out of those peripheral veins, you can see thrombophlebitis, tissue necrosis, and all of that. So it would be a vesicant, similar to some of the chemo drugs we've looked at before. So up next, we have naloxone. I'm sure most of you have, or at least somewhat familiar with naloxone. Let's see. Daniel's asking, is there a preference when using the calcium gluconate as compared to the calcium chloride? Yes, it depends. So for one, it depends on the access you have. So if I have a patient who has central access, and I don't mind, especially if volume is a concern, I don't want to give as much volume, then calcium chloride is totally fine, right? If it is something where I have a peripheral vein, that's the only thing available to me, then if we have time, right, the patient's not actively coding, then I prefer using calcium gluconate, because it's easier on the veins, you're less likely to run into an issue in terms of thrombophlebitis and whatnot. So those are the main concerns you see there. If, for instance, I have a patient who is, say, coding in the ER and they just came in off the street, for instance, and they only have a peripheral line, that may be a case where calcium gluconate may be reasonable, right, or maybe preferred. If it is someone who's coding in the ICU and maybe they already have a central line placed, then calcium chloride is going to be the one to go with every single time. So those are the main things you see there. You see a lot more calcium chloride used probably in the ICUs, but you can still see some in the ERs as well. So. Especially if you have a patient who's out on the floor and they need calcium replacement, then typically we'll go calcium gluconate regardless, just because it's a little bit safer of a drug for those situations there. So next up we have naloxone, which most of you are pretty familiar with. We know this is the agent of choice to help reverse opioid intoxication. It works strictly as a opioid receptor antagonist and helps to reverse all those CNS and respiratory depressant effects of the drug itself. And remember, it's a very safe drug to give, so you will see that if you have someone, especially if they're opioid naive, like if I have a kid who gets into an opioid and you give them a dose of naloxone, they'll wake right up, they'll have no issues with that whatsoever. If it's someone who's chronically on opioids, remember you can induce withdrawal, which is not fatal from opioids, but is not very, the patient's not going to like you very much. Nurses might not like you, and that patient starts to have diarrhea everywhere, vomits. There could be an aspiration risk, depending if they have other CNS depressants on board. So there are some concerns there, right? So that's something you may want to maybe use a small dose and give more, because even though it's short acting, maybe like 20, 30 minutes, you can always give more, right? So typically, start with low dose, see how they respond. Typically the best response you can get from someone who is receiving naloxone, especially if they're chronically on opioids, is they just start yawning, right? Once they start yawning, that kind of tells you their brainstem is picking up on all that extra CO2 they're holding on to, and then they will start to try to expel that by taking those big breaths in. If they're asleep, that's okay. That's probably fine. These patients don't have to be awake, right? They just have to be breathing. But with the advent of end-tidal CO2 monitoring, that becomes a lot easier too. We can see very specifically like what's going on. If they're retaining a lot of CO2, that may mean we need to give some more naloxone in order to help them expel that more forcefully. So, and you're going to see more outpatient availability of this as well, especially here in Florida. We do have access to this. Police officers are now carrying this, especially the sheriff's department, which is good because as first responders, I think police officers show up more often than not as the first people. So if you have someone who's not breathing actively, that can help to stave off some of that hypoxic injury potentially. And remember, if you're educating patients, if they have naloxone available to them, like it's going to be someone else giving it to them, right? Because they're going to be passed out. Make sure they know call 911, because this stuff is not going to last very long. The patients have a tendency to resedate, especially with stuff like methadone or buprenorphine or things that have long half-lives, right? So up next is going to be dextrose. So this is going to be good for basically hypoglycemia. We'll also see this being given in conjunction with some other stuff for hyperkalemia in just a little bit too when we get into that. There are three main varieties you're going to run into when it gets to comes to dextrose. So there's going to be the 10%, 25%, and then 50% dextrose. Typically, you're going to find the higher the concentration you get with the dextrose, the more likely are to see some vascular injury. It can be pretty irritating to the veins. So if you're pushing, say, D50 in a peripheral vein, that may not be very comfortable for the patient. However, if they're passed out because they're hypoglycemic, then that may be less of a concern. Typically, we like to go lower concentrations, especially for the younger kids. So have like an infant or a neonate who's hypoglycemic. Most often, we're going to end up going with like a 10% solution. If it's a little bit older, maybe older than 2, then you can go with like a 25% solution. Keep in mind, though, that the volume is wildly different, right? So, one of the things you'll see in code situations, people say, well, give an amp of dextrose. I have a slide on this a little bit later on. Well, an amp, if anyone even knows what that refers to anymore, it's an ampule. Most of the stuff doesn't even come in as an ampule, right? They're usually pre-filled syringes. But it's like, give an amp of calcium or give an amp of dextrose, right? Because it sounds like you're on an exciting TV show and they've heard that before. So anyway, so that can be really misleading, because if you say give an amp of dextrose, well, you got to be specific in terms of which concentration you're giving. Or if you say give an amp of calcium gluconate, calcium chloride, like what do you specifically want? So always be very explicit and clear with what you are expecting out of your fellow healthcare professionals and what the patient's going to get, because the volumes are quite different here, right? So if I'm giving D50 to a patient, I only need 1 to 2 mLs per kilo to get that specific dose. The equivalent dose, so if I'm giving, say, D25, is 2 to 4 mLs per kilo. So it's easy to either give too much or too little if you're not talking about the right concentration. So you're kind of seeing a big through line through most of this talk here is, again, be specific, be aware of the different concentrations you might run into, right? Because a lot of errors happen here. So getting into the algorithms here, again, this is the 2015 update to the algorithms. Don't believe anything has changed too recently, at least by the last time I checked. But if there is any discrepancies, please let me know. But basically, in terms of medications, not a lot has changed anyway, right? So I won't get a lot into the the actual shocking of the patient and the electrical therapy here, but I do want to kind of show you where these different medications are coming into play. So let's say we have a patient who falls out in the field, EMS arrives, they start CPR up. Again, you're going to be questioning, okay, is this a shockable rhythm or not? Your shockable rhythms tend to be VFib and VTAC, right? So basically what you're going to find here is that, if a shock is indicated, that's going to be the best thing for those patients there. But note here as well that once IV access is established, or maybe IO access or something like that, you're going to be giving epinephrine every 3 to 5 minutes or so. And for most adult patients, 1 milligram of epinephrine is going to be the thing to go with. And this is a really funny thing I always get into. We had, whenever we have our trauma simulations, our emergency medicine simulations over at FRTG, we usually will, allow our students to kind of run the show, right? And so what's really funny is, like, when you do it before you go on to rotations, you will think you know some stuff. And I always recall this one student who was like, okay, we got this coding patient, let's give 1 gram of epinephrine. And I go, okay, you want to give 1 gram of epinephrine? And she says, yes, right now, give it. I said, okay, the patient's heart exploded and now they're bleeding out of their eyes, and but it's just so funny how forceful she was in her recommendation, and I'm sure she was not the only person that would have done that same mistake. So again, knowing your doses can be important for some of these more life-saving things like epinephrine, right? Anyway, when they come back from rotations, though, they're much more confident and they're much more knowledgeable, and so that same mistake did not happen, which is a testament to their growth over that year. But regardless, I'm sure everyone's going to be scared about making that same mistake now, but don't worry about it. It's okay. This is why you're in school and learning. Okay, so anyway, note here that you're going to be giving basically epinephrine every 3 to 5 minutes, and you'll be giving these shocks as indicated. The other big thing to note here is you may give amiodarone. So if a patient has been shocked several times and they're still not getting back into normal sinus rhythm, this is when we can bust out our amiodarone and try to help them with a chemical sort of cardioversion as opposed to an electric cardioversion here, right? So that's going to be the big thing here. If amio is not available, you may consider trying something like lidocaine. I'm sure there's somewhere over here that mentions that as well, right? So on the other side here, say you're in asystole or PEA, there's no shocking that's indicated here. Note that things like amio are not really going to be indicated because, again, the patient has no rhythm whatsoever. And so also here, this is where epinephrine is going to be given. And same dose, same thing, every 3 to 5 minutes or so, you're giving epinephrine. Nothing really notable here. There's no atropine being given because the patient's not just bradycardic. And again, they have no rhythm whatsoever, right? So this is where we're going to be busting out our epi every 3 to 5 minutes. So pretty straightforward from a medication standpoint, which is nice, right? It's the other stuff comes into play, though, when you're considering, okay, well, why is the patient coding in the first place? And so some of that comes about with your H's and T's, right? These are reversible causes for patients to be in a cardiac arrest. And so, for instance, again, I have to bend over my microphone here, but things like, if we're looking at hypokalemia, right, we have drugs that we can use to fix that. If they're hyperkalemic, we'll look at some drugs in just a few minutes that you can use to help to reverse that. Or say, for instance, they have some toxins here, right? Maybe they have an aspirin overdose and you need to give them bicarb in order to help correct that. Or they're acidotic and you're giving them bicarb. Or say they're in torsades, you give them magnesium. So a lot of the drugs are going to be on a very case-by-case basis, whereas things like epinephrine are going to be kind of your bread and butter. Like everyone's going to be getting that every 3 to 5 minutes or so. Okay. So again, I can ask a test question that says, okay, patient's gotten, say 3 rounds of epi, and then they have their labs come back and their potassium is 7. Like, what do you want to do? What medication will be indicated now? And we'll learn about that in just a few moments here. But those are the kind of things I can ask about, sort of on a case-by-case basis. Which drugs might be indicated? Which do you want to give? What's most appropriate? That sort of question. So looking at if they're tachycardic, but they still have a pulse, so they're not technically coding right now, but they may be heading that direction potentially, right? So this is where you run into a lot of like your SVTs and things like that. A lot of this is going to be based on whether or not, one, if you can find reversible causes. So is it due to heart failure, or are they in cardiac, having myocardial ischemia and things like that. But then getting into it, do you have a wide or narrow complex rhythm? Typically for the narrow complex tachyarrhythmias, this is where we're going to be getting into things like our adenosines, right? Note here that adenosine is going to be the first thing to give, especially if it's regular and it's SVT. But as an alternative, you can consider something like a beta blocker or calcium channel blocker. Remember, those are class 2 and class 4 antiarrhythmics respectively, and these can be useful, right? So you can give something like, metoprolol. You can use something like labetalol IV. These are decent ones. Diltiazem, verapamil. So note is going to be the non-dihydropyridine calcium channel blockers. Those could be used there as well for those tachyarrhythmias with that narrow complex. If it's going to be wide complex, then that's where it gets a little bit more complicated, and this is where we consider looking at things like amiodarone potentially. This is where we started getting into, maybe even like lidocaine might be indicated depending on the situation. So a lot of this is going to be more specialized here. But for the narrow complex arrhythmias, adenosine first, and then you start to consider things like beta blockers, calcium channel blockers, or maybe even like amio may be indicated in those cases there. Okay. If we have a patient with bradycardia, remember this is where our atropine comes into play here, right? So this is where atropine can be effective as an anticholinergic, antimuscarinic specifically to help get that heart rate back up. Note here, you give it every 3 to 5 minutes, kind of similar to what you would do with epinephrine. And then you also want to consider some other infusions as well. We're going to get into these pressors here a little bit later, so dopamine and epinephrine. We'll talk about these as being positive iono and chronotropes, and we'll get into how we use those in just a little bit. So how do you keep it all straight, especially in peds? And in fact, if you ever want to see a high tension situation, go into an adult ER and bring in a coding pediatric patient. There's nothing I've seen patients or providers, even those that are very well versed in what they do, as anxious and really kind of scared when a pediatric coding patient comes in, because one, you got to consider all the doses as being quite different. It's a kid, so that already kind of raises the anxiety level already. But here's some things to keep it straight, and here's some things that kind of help you have a better resuscitative experience when dealing with a pediatric patient, right? So one of the things that can help us out are code sheets, because not everyone can remember how to do what the doses are right off the top of their heads, especially when you're in a really anxious sort of high tension situation. A lot of people even have a hard time doing math. Math becomes quite difficult when you're trying to figure out a very specific dose, even if it's something simple like multiplying the patient's weight by 0.1. Even that can become quite difficult when you're in a really high stress situation. And so we have these code sheets that are basically designed for specific patient weights. So typically they'll have like different breakdowns where you may have it, every 5 kilos, every 10 kilos, something like that. And they will typically include all of your resuscitation medications and intubation drugs as well. So your paralytics and induction agents additionally to all the resuscitative stuff we talked about today. The nice thing though is it takes out the calculations and also lists the volumes. This is really important in terms of what the nurse needs to know in order to give. So if the nurse is drawing up the medication, she doesn't care what the dose is. She cares what the volume is needed to give that patient, because that's what she's looking at when she's looking at that syringe. So that really helps out as well. A general tip though is if a patient is in between weights, you generally round up. If they're in a code situation, I'd rather give them a little extra than not enough. Okay. So here's an example of what a code sheet would look like. This is an example of one that we had designed at Nemours. You will find different ones everywhere you go. There are some that are sold as like a product. There's lots of different ones out there. But essentially what you can see here is when you'll have a sheet specifically for the patient's weight. We also include things like doses for defibrillation and cardioversion. And then we have all of our medications here, right? Notice that we not only have the dose that we would administer to a patient of that particular size, but we also have the volume, because this is what the nurse would want to actually draw up to hand over to give to the patient specifically. Okay, so just to give you an idea of how we would use those. Here's an example. The intubation drugs would look like too. So again, we'd have that included because a lot of patients who are coding have to get intubated in a lot of cases, or maybe done it beforehand. So it's good to have those meds available to you as well. Here's an example of the Broslow-Luton tape. So this is something you may see out there occasionally in order to help out with resuscitations and pediatrics. Basically, this is something where you'd have the patient at the head of the tape, and then you kind of lay them out lengthwise, and then wherever they ended up in terms of the color, that would be basically the category they fit into. So for instance, here this patient looks like he'd probably fit into a yellow, maybe a white, depending on if it's fully stretched out, but a yellow. So you can kind of surmise he's probably between 12 and 14 kilograms. As you might imagine, there's some drawbacks to this. So one, patients may be over or underweight, and that may be under overdosing the patient based off of this. You may find that maybe the patient has chronic contractions or something, or maybe make it difficult to get the full length of the child on there. I've seen providers flip this and use the wrong end, so that's why they have a big red thing that says patient's head here, but I've seen providers still do this incorrectly. So this has some limited utility, but you'll find all kinds of systems like this out there for pediatric patients potentially. So some other tips that I find really important for having a good, safe, resuscitative experience is you always want to make sure that you call back things to the provider, or make sure people are calling back things to you if you're the one that's in charge. Because a lot of you may be thinking like, well, I'm never going to be the one running a code, but you might be, right? So if you're especially out in a smaller environment where maybe there's one doc and there's you, and you have two patients that are coding, well, guess what? You got to step up and do your thing. So it's really important to remember some of these tips here. So one, you always want to make sure you're calling back orders, or make sure people are calling back things to you. So if you say, I want 1 milligram of epinephrine given IV, have someone call that back to make sure that they understood what you just said, right? Because they have this term called tight coupling, which means the time from when you say something to the time when that patient gets that drug is extremely short, like within seconds, right? So this is one of those things where you make sure you call out things, you call back things to make sure that understanding is there, to make sure the patient gets exactly what you want. So as an example, I'll tell you, like when I'm running, when I'm helping to facilitate a code, say in the peds ER, right? So pharmacist will be there to help out, and they'll draw up meds and things like that. A lot of what I actually do is trying to anticipate where the patient's going and what the provider's going to want to do. So if I start to notice, hey, it looks like this patient may need to get intubated, I've already got the kit out by the time the provider says, hey, let's go ahead and intubate. Right? So a lot of it's kind of a guessing game, like, okay, where do I think things are going? Is the patient acidotic? Okay, bicarb might be indicated here. Or maybe they're hyperkalemic. Okay, I'll make sure the calcium is ready to go. But I make sure that when the provider says, hey, let's go ahead and give 1 milligram of epinephrine. I say, okay, so I draw it up and I hand it over to the nurse and say, okay, we're going to give 1 milligram of epinephrine. Make sure everyone can hear me. The nurse will say, okay, 1 milligram of epinephrine, and then before she even gives it, she'll say, okay, I'm about to administer 1 milligram of epinephrine. The provider says, yes, go ahead, go for it, right? So that way, everyone is on the same page to make sure everyone can kind of hear it. So there's a lot of repetition, and it may seem like really simple communication, but that helps to keep errors from occurring. So again, be precise. Saying an amp of calcium really doesn't mean much. Like, do you mean calcium chloride, calcium gluconate? How big is the amp you're dealing with? Like, you want to be specific, okay? I would like 1 gram of calcium chloride given IV now, okay? That's specific. And then that also occurs like when you're talking about things like drips and whatnot. So for instance, start dopamine at 5. 5 what? 5 mics per kilo per minute, 5 milligrams per kilo per hour, 5 ducks. Like, I don't know what you mean, right? So be specific, because that helps to prevent errors from occurring. I remember I had one case where a patient was coming in. They were complaining of chest pain. They were using sublingual nitro, wasn't working, and they're very hypertensive, so they decided to start the patient on a nitroglycerin drip. And so the provider, I think he's a resident at the time, just said, okay, we'll go ahead and start the nitroglycerin at 20. Okay, well, the nurse said, okay, well, I got this pump here, and the pump had different options. It had mics per minute or had mics per kilo per minute. And so she didn't know which one to pick, so she just picked one at random. She picked the one of those mics per kilo per minute, whereas the provider wanted mics per minute. So as you might imagine, that per kilo is important there because that then multiplied the patient's weight by all that drug. So basically that means that that bottle of nitroglycerin got ran in all at one time, basically, very, very quickly. No one's paying attention. All of a sudden, the patient's like, man, I got this like the worst headache ever, and I'm feeling really dizzy because the bottom out is pressure, right? So that's one thing to consider there. Ashley says, in an emergency medicine lecture, there was a slide that said exogenous bicarb can worsen intracellular acidosis. Is that due to trying to correct too quick? Maybe not too quick. I mean, trying to think when that comes up clinically, because I mean, like if your patient's like sitting at like 7.1, 7.2, like you kind of got to correct that. I'd have to see the context for the slide if I were to speak more intelligently about it. There might be some context surrounding that I would need to look at before I could say anything definitive. I would tell you clinically that doesn't come up too often, but it depends on the situation, right? So for instance, if I have a patient who is, say, very acidotic, due to DKA, right? Well, I know the issue is not necessarily that the issue is they don't have enough insulin, right? So you can try to correct it via those other means. If I just slam bicarb, but I don't actually deal with the underlying issue, then I'm not really helping the patient much, right? So if it's because they can't get any glucose into their cells because they have no insulin, then giving them a bunch of bicarb doesn't help that intracellular process, right? So I'm thinking something like that. If you're in that kind of situation, then yeah. So fix the underlying issue, and then you may not even need the bicarb in some cases there, right? So hopefully that answers your question, but if not, let me know. So all right, so any questions on that currently? Let's see where we're at. Let's see if there's any questions. I do have one question here. Have you seen PAs running codes, or is it mainly MDs and DOs? I will tell you that. So I can speak to my experiences. I have not personally run into a PA specifically running codes, but I'm definitely aware of PAs running codes, right? So, and again, kind of given where my experience is. So, like, I did my 2 years of fellowship at in downtown Jax, where it was a big teaching facility. So there was no shortage of physicians there to run those. So a lot of like residents and things like that. And those kind of places, PAs might be more relegated to like fast track or different areas of the ER where they may not be exposed or may not be in that situation where they're running those critical care beds, right? And then at Nemours, like for instance, we mainly just use peds EM providers, and then we have a lot of nurse practitioners. That's just the way they wanted their setup, and that's what they do, right? But I am certainly aware. I've talked to plenty of PAs. I've talked to many students who've gone on to work who have they work in a smaller facility, especially where if the doc is busy with another coding patient, and you have someone else come in, you got to do something for that patient, and so the PA may run it in those situations there. So that's why we teach it to you guys, because you need to be aware of how to manage that, because you never know when it might happen. And again, you may have someone that falls out in the middle of Walmart, assuming we ever get back out to the real world, and you need to start CPR, right? So you need to know these kind of things in order to be able to respond to those kind of issues there. Let's see if there's any questions there. I remember one time I was doing an ACLS course, and there was we did a simulation to go through it, and that was really fun because I had the chance of calling on people randomly. So there's like RTs there, and nurses, and docs, and PAs, and MPs. Everyone's kind of taking this class, and I got called up to run the mock code. Essentially, they're okay. Well, you're the provider now. I said, oh, okay, and I got up there, and it was a lot of fun. Actually getting to kind of direct everyone, make sure okay, things were happening exactly how I wanted to. But then they realized I should not have that much power, and so they said, no, never again, you shouldn't do that, go back and pull up your drugs. Okay, so without any further ado, I think I have some extra time here. I'm sorry, can you explain again when you use adenosine versus amiodarone? Yes, so adenosine, so typically if you have a patient comes in with like a regular tachyarrhythmia, like it's diagnosed as SVT, specifically adenosine is going to be the first thing you're going to go with there. Amio is going to be more used as like a backup to that, or like for ventricular arrhythmias, or because again, adenosine is kind of very narrow spectrum of what it's going to be used for, so basically just SVT. If that's not working, then you can consider things like a beta blocker, non-DHP, usually IVs, how we're administering those. But then if that's still not working, then you can go ahead and give amiodarone as an alternative to that. So I'll give you an example. I had one time had an 8-month-old, I think. Patient came in and they were in SVT, so I think they're attacking like close to like 200 beats per minute almost. So it was a very, very fast rate. And so we had the cardiologist that came in and were helping us out with that. And so we started with the adenosine first. Well, we tried the non-farm stuff too, right? So we tried to use, I think I had like ice packs and things like that. And again, it's an 8-month-old, so they really couldn't cooperate very much with us. So like, okay, bear down. Like, they're an 8-month-old, right? But so we tried adenosine first. We gave 2 rounds of that, and the patient kind of broke, went to the normal sinus rhythm, but then went right back into the SVT, right? So they said, okay, well, let's go ahead and try using, I believe we used diltiazem at the time. So we used diltiazem IV, trying to give that as a continuous infusion. That helped get the rate down a little bit, but didn't really kind of fix the arrhythmia. So then at that point, they're like, okay, well, and I think the patient's getting a little hypotensive at that point too. They're kind of on the cusp of coding, but weren't quite there yet. Still pulses. So they're worried about the hypotension from the diltiazem, so they went ahead and said, okay, let's try the amiodarone now. So then we ended up trying that. In the meantime, the patient ended up coding. I think they actually ended up on ECMO. It was actually the first time we did ECMO down in the ER. So that's a course that could go. I don't know if it's the same course for every single patient there, but again, amio is a very wide spectrum. It can be used to treat atrial, ventricular arrhythmias, kind of used for anything. So it's a good backup to stuff like adenosine potentially. So hopefully that answers the question. Let's see. How many slides do I have left in this section here? Because let's see. I've got 24 slides left. I'm trying to think, because I might end up not having enough material for a whole class session. So I'm just going to go ahead and get through this since we have time, and then we may end up having being able to miss a session, which might be okay for some of you, because I kind of speak faster here because I don't have anyone to talk to in front of me. So it is what it is. So I want to get into talking about chronotropes, inotropes, and then vasopressors here. So as I mentioned, chronotropes are things used to help increase the speed of the heart contraction. So the actual rate is going to be increasing. Inotropes are going to be that contractility of the heart, so you actually get better cardiac output because you're getting better squeeze. And then vasopressors are really anything that help to, as you might imagine, they press the veins, and so you're going to be in the arteries, so you're going to be finding they help to increase peripheral vascular resistance, okay? Because we talked about things that help decrease peripheral vascular resistance, but we really haven't covered a lot of things to help increase that. And you may find that some of these drugs can fill multiple roles when we get into them. So things like norepinephrine or epinephrine can fulfill multiples of these, or potentially all 3. So dopamine is the first one I wanted to talk about here. Again, we have endogenous dopamine naturally, but if you recall when we talked about Parkinson's, you can't just give dopamine peripherally because it ends up getting metabolized and it doesn't cross the blood-brain barrier all that well. That's why you end up doing things like levodopa, carbidopa, right, as a precursor molecule. But peripherally, we can give dopamine and go ahead and get all the peripheral effects we would like to see. So one of the things it can actually do is to help stimulate release of epinephrine and norepi, and it also acts as a kind of a precursor molecule. So it itself can be metabolized into things like epi and norepinephrine there. So the interesting thing about dopamine, it has what they call a dose-dependent effect, meaning as you change the dose, you can get varying effects out of it. So at really low doses, say you're going between, like, say, 1 to 5 mics per kilo per minute, you end up finding that you have not much pressor effects or cardiovascular effects, but what you do find is it helps to increase renal blood flow and help with urine output to some degree. So I'll tell you, clinically, we don't use it at that dose very frequently, though, right? It's not usually recommended. Although at higher doses, say in the mid-range dose, say between 5 and 10 mics per kilo per minute, now we're getting more beta activity, right? So we're going to be seeing more beta-1 activity specifically to where you get increased heart rate, increased contractility, and better cardiac output, which is nice from a, say, if you have like a CHF exacerbation or something, right? They're coming in, the cardiac output's not great, but you want to get that contractility and heart rate up. This is where medium dose dopamine can come into play, okay? And then at high doses, say 10 mics per kilo per minute up, you still have all those nice beta effects, but now you add on the alpha effects. And so this is where you can use it as a vasopressor in addition to a positive ion chronotrope. So you're going to see increases in blood pressure due to that vasoconstriction on the alpha 1 receptors, if you recall. See, Ben says, maybe a silly question, but if you had a patient with Parkinson's requiring a pressor, would you use a different drug than dopamine if they already had been taking this? I don't know if there's any specific contraindication to doing that. I kind of don't like dopamine a lot anyway. I'll tell you why in just a little bit. But there's no specific contraindications. I think you can still administer it. I don't know if there's any decrease in efficacy or anything like that. Maybe potentially you could see some increased activity if they're on like, say, a monoamine oxidase B inhibitor or like selegiline, or maybe they're on like entacapone or something like that. But yeah, I'm not aware of any sort of contraindications there. But in terms of dopamine, some things you would want to be cautious with is, one, if you're administering it and they're hypotensive, make sure they have their intravascular volume in check here. So frequently patients will get fluids first, and then you follow up with a vasopressor. And so make sure you're using IV crystalloids. That's your normal saline, that's your lactated ringers, things like that, right? Due to the beta stimulation, you can see things like PVCs, sinus tach, palpitations. These are pretty common either with medium or higher dose dopamine being given here. At even doses higher than what we were mentioning with the, say, 10 to 15 mics per kilo per minute, that's where we start to kind of run into a plateau in terms of how effective the drug can be. We see increased risk for arrhythmia. We see increased risk for things like splanchnic vasoconstriction, meaning you can get decreased blood flow to things like the GI tract, leading to ischemia, which can be very problematic and lead to all kinds of issues down the road. And you'll typically see as well that when you're giving vasopressors, as a general rule, it wants to make sure that the body's perfusing the heart and the head, which means that other organs can take a back seat, meaning you can see peripheral issues in terms of decreased peripheral circulation. You can find decreased renal perfusion. You can find decreased GI perfusion as well. So those are concerns we always think about in terms of when we're using especially high-dose vasopressors for a long time. So the alpha stimulation can cause things like cold extremities, like I kind of mentioned there, renal hypoperfusion, and chest pain. And this is important too. Like if you have a patient who's, say, septic, and you need to give them, say, a bunch of antibiotics, say for instance like vancomycin and gentamicin, and these pressors are being used to help get their blood pressure up, but they're decreasing renal perfusion, you can see how that's going to be a problem where it helps to decrease the ability to clear those drugs. And so you really have to make sure you're taking a close look at their medication profile to make sure that you're not being too aggressive with the antibiotics, given the fact that their kidney function may be taking a hit, not only from the sepsis, but also from the vasopressors we're giving as well. Okay. Most of these vasopressors can also cause really severe tissue extravasation should you have any issues with that vein there. And so because, again, it's going to cause all those little vessels to start to compress down, it can cause decreased tissue perfusion, necrosis there. And we actually end up treating that with a drug called phentolamine, which is an alpha blocker. So it basically helps to reverse the vasopressor effects of the drug itself. And that'll be pretty similar to all the pressors here we're talking about in terms of how you would manage that extravasation. Next we have epinephrine. So again, we've talked about this previously before. We've talked about it as being either an inhaled drug, intramuscular drug, topically administered, but when we're talking about it in terms of this, we can use it as a vasopressor. Now in ACLS, we talked about using this kind of intermittent doses every 3 to 5 minutes. In this case here as a vasopressor, this is going to be a continuous infusion, so much smaller dose, but given over a long period of time. And the nice thing about epinephrine is you get a nice balanced effect between alpha and beta activation here. So what you end up finding is that this can help out when patients are both bradycardic and hypotensive, or if they're hypotensive and have poor cardiac output, epi might be a good option for those patients there. And again, similar side effects to dopamine, basically because they're all working through the same exact receptors, right? Next is dobutamine. This one is different than dopamine because it works as purely a beta-1 agonist. So this is only going to be a positive inotrope to help out with cardiac output. You shouldn't see a whole lot of increase in heart rate necessarily, not as much as you would see with something like dopamine, but you're going to find that it's really good for like decompensated heart failure, especially if they're, say, having decreased cardiac output, but they're hypertensive, for instance. You don't necessarily want to get their pressure up any further. This is where dopamine can come into play. Main side effects, though, is it's going to be arrhythmogenic, meaning your risk for things like tachycardia, ventricular tachycardias, and things like that are going to be higher as you're giving this. Okay, and those patients, due to their chronic remodeling and things like that, may be at risk for that anyway, right? Next is isoproterenol or isoprel. This is another pure beta-1 agonist. I've seen this mostly been replaced by dobutamine, but I still see it used for pediatrics, especially in cardiology for like different provocative kind of testing. So you may see this used occasionally, but if you ever hear isoproterenol, think about it like as dobutamine works as just a pure beta-1 agonist. Next, we have milrinone. So this is going to be another good one for patients with decompensated CHF. This is basically going to be an inotrope plus a vasodilator. So this actually works by blocking phosphodiesterase. And similar to when we talked about things like sildenafil for erectile dysfunction, that worked on PDE5. This works on PDE3 specifically. So it helps to increase cyclic AMP levels in the heart, and it's going to lead to increase in contractility. It's also going to lead to smooth muscle relaxation in the vessels. So you get a nice balance between increased cardiac output, decreased peripheral vascular resistance, which may be helpful in patients with that decompensated heart failure. Now, if they're hypotensive, this would not be a good one to give them, right? You want to use something more like an epi or dopamine or something like that, right? But the main place you're going to see milrinone being used is for decompensated CHF. We don't like to use this long term, maybe because we do see an increased risk for ventricular arrhythmia. So that's one thing you would want to be cautious with. And it can cause hypotension, so watch out for that as well. Then we have norepinephrine. Levophed is the brand name. This frequently got called leave 'em dead, so that was kind of the pet name for it, to where if you had a patient who needed Levophed, you better just leave them dead because you're not going to get them back. Nowadays, that's not really been the case anymore. I'm seeing a lot more providers, especially newer providers, use this as their go-to. And in fact, I like this as my kind of go-to presser. So if I have a patient who, if I get a call from the poison center, a patient's hypotensive due to like a beta blocker ingestion or calcium channel blocker, like Norepi is kind of the one I go with almost 10 times out of 10, right? But the reason why we like this is that it does have, a balance between beta and alpha effects, whereas epinephrine is kind of like a one-to-one almost. You can kind of think about norepi as being a better, little more activity at alpha receptors than beta. So say, for instance, I have a patient who is tachycardic, but they're hypotensive. Say they took like a TCA and they're having anticholinergic effects where they're tachycardic, but their blood pressure is bottoming out because you're blocking all those alpha-1 receptors. I kind of like norepinephrine in those cases there because it's not going to do too much on the heart to increase risk for arrhythmia, but it will help out with the blood pressure, right? That's kind of the main thing I'm going to be using it for. And so that's why I prefer that for a lot of cases, especially drug-induced hypotension. But so that's kind of the difference between here. If you don't need a lot of kick in the heart, but you definitely want to get that blood pressure up, this is where norepi can play a role. Now, if you just want a pure alpha agonism, this is where phenylephrine can be used here. And so this may be seen being used as just a pure alpha agonist. You'll typically see phenylephrine in a lot of like over-the-counter cold preparations and things like that, where it doesn't really work all that well. But used IV, it's actually a very good agent here. I see this used a lot in surgery by the anesthesiologist, where they may just need a little bit of increase in blood pressure. They can give just small doses to the patient to try to manage that. But the issue with using phenylephrine and why we don't go with that one as a go-to if patients are hypotensive is because you tend to see a lot of that decrease in perfusion to a lot of those extra organs, right? So like your kidneys and your GI tract and all those things, you tend to see a lot more decrease in perfusion of those organs, and you end up running into more risk for having tissue necrosis and things like that. So phenylephrine, I see this more as like an add-on agent if the other agents are not really working all that well, right? So if they're on norepi and they're on dobutamine and they still can't get the pressure under control, then they may add on phenylephrine there. Next, we have vasopressin. This is one you'll typically see used a lot in the ICUs. Basically, vasopressin is just ADH, right? So it's antidiuretic hormone. You may use this in things like diabetes insipidus, but we also like to see it used for other things as well. So things like GI tract hemorrhage, if you have like esophageal varices, this can be helpful for helping with that. But we like it in septic patients because it works as a vasoconstrictor. It still helps to hold on to fluid in the kidneys such that you keep the intravascular volume replete. And so this is maybe used as an add-on agent. You wouldn't use vasopressin by itself to manage blood pressure. So if you had a septic patient who's hypotensive, you probably start them on norepi first, and then maybe adding on vasopressin if you need some additional help there. We used to use it during ACLS, but that's been removed from the guidelines, so I wouldn't worry too much about that. And for the most part, you're going to find that it's pretty well tolerated. You may see some peripheral ischemia, but the biggest thing you can expect to see is water intoxication, which makes sense because this antidiuretic hormone is going to stimulate a thirst response. And so if patients are still awakened with it and they're on this, they may want to have a lot of water and salt intake, and so that's a possibility. Maybe hyponatremia can develop. So how do you pick an agent? Typically, you have to consider the condition. So if they have poor cardiac output, but the blood pressure is okay, Consider things like isoproterenol or dobutamine or milrinone, right? Or maybe even like an intermediate dose dopamine, for instance, because all you need is really that kick on the heart, right? You don't need a whole lot of effects on the blood pressure. Well, if cardiac output and systemic vascular resistance is diminished, then that's where we start to look at things like higher dose dopamine, norepi, epinephrine, and things like that are going to be more appropriate. If the blood pressure is marginal, but they have okay cardiac output, this is why I like things like norepi. I'd probably choose that 9 times out of 10, and then maybe phenylephrine is maybe a second or third line added on agent. And then for septic patients, vasopressin is used pretty commonly as an add-on to some of the other pressors like norepi or dopamine. So any questions on that? Feel free to post them up. Again, this is kind of like a few miscellaneous topics for ER stuff. See, no other questions yet. So then let's talk about hyperkalemia real quick. Actually, I'm kind of considering it, but I don't know if half of you guys are still feeling it, if you want to keep going on or not. Yeah, I'll probably cut that off. I know we don't have too many slides left, but this will feed right into the tox stuff, so I'm not too worried about it from that perspective. We're going to have plenty of time, I think, to cover all of this. So I think I'm going to go ahead and cut it off there. Do you guys have any questions before I let you all go? Feel free to post them up in the chat here. All right, well, thank you all for joining me. I really appreciate it. Go out there and watch Tiger King if you haven't, if you have some extra time, because that show is real wild, but a lot of fun. And you'll definitely have a bigger appreciation for Florida, especially if you've not lived here your entire life. So no problem. You guys have a great day, and I will see you all next time.